This is a video over blood pressure control. So our body senses blood pressure at the carotid sinus and aortic sinus. There's specific mechanoreceptors called baroreceptors. They're going to return information about this pressure to the medulla, where we have our cardiac and vasomotor centers. So these, again, are stretch receptors called baroreceptors. These signals are returned to the medulla from the carotid sinus by cranial nerve number 9, which is your glossopharyngeal nerve, and from the aortic sinus from cranial nerve number 10, which is the vagus nerve. As far as blood pressure control, with our cardiac output, total peripheral resistance, and blood volume, those would be the three factors that we can physiologically change. So cardiac output equals heart rate times stroke volume. So to increase cardiac output would increase blood pressure. So we can have sympathetic nerve stimulation of the heart. So sympathetic stimulation of the SA and AV node will have a positive chronotropic effect to increase the heart rate. Sympathetic stimulation of the myocardium will have a positive ionotropic effect and increase contractility. Both those are going to increase your cardiac output, increase blood pressure. Now, to decrease blood pressure, well, this will be through the vagus nerve. So parasympathetic stimulation of the nodes, releasing acetylcholine and causing a negative chronotropic effect, slowing down the heart rate. And also at the same time, from the vasomotor centers or cardiac centers, we will inhibit the sympathetic stimulation of the heart. So decreasing cardiac output and decreasing blood pressure. As far as total peripheral resistance goes, this is the basically space we have in all of our peripheral vessels for our blood volume. So this is affected by sympathetic tone. So again, the tunica media of blood vessels does not have parasympathetic innervation, just sympathetic innervation. So the more sympathetic outflow, the more vasoconstriction, which will increase our total peripheral resistance, making that space smaller and increasing blood pressure. If we have vasodilation, we decrease total peripheral resistance and we increase the space the blood has, and we will decrease blood pressure. As far as blood volume goes, this is largely controlled by the renin-angiotensin-aldosterone system. So how this starts out is in the kidney. So if the kidney feels it's underperfused and it senses that, it will release an enzyme called renin. Renin converts angiotensinogen, which is a protein from the liver, to convert it into angiotensin 1. Now, angiotensin 1 is converted to angiotensin 2 by another enzyme from the lungs called angiotensin converting enzyme. Now, angiotensin 2 has three main effects. One, vasoconstriction, so it's also going to increase total peripheral resistance. And then its other two effects will be in two different hormones. So first, antidiuretic hormone from the posterior pituitary. This hormone is made in the hypothalamus, stored in the posterior pituitary, and usually gets released or has increased release when there's increasing blood osmolarity. But here, angiotensin 2 will increase the release of antidiuretic hormone. This binds to receptors in the collecting duct of the nephron and causes water reabsorption, effectively increasing your blood volume and making a more concentrated urine. The other hormone angiotensin 2 is going to stimulate is aldosterone. So aldosterone works in the collecting duct of the nephron, causes sodium reabsorption, potassium secretion, and water reabsorption due to the fact of pooling in sodium. Water will follow by an osmotic effect. So by increasing both of these hormones, we're going to effectively increase blood sodium and blood water, increasing our blood volume, which will overall increase our blood pressure. Now, there are plenty of hypertension drugs you're going to have to learn. Obviously, some basics in the renin-angiotensin-aldosterone system, so ACE inhibitors, so angiotensin converting enzyme inhibitors, so all the drugs that end in pril, so enalapril, ramipril, lisinopril, and so on, will block some of that enzyme conversion of angiotensin 1 to angiotensin 2, so to lessen angiotensin 2's effect because there's less of it, and will lower our blood volume and decrease blood pressure, and also decrease peripheral resistance. Now, drugs like angiotensin receptor blockers will actually blind the receptors that angiotensin 2 is binding on in these different areas, and those are your ARBs. So those are your sartan drugs, so losartan, valsartan, telmisartan. On the heart, we can give different drugs like beta blockers, which will block the beta receptors in the heart and decrease our cardiac output. So those are our metoprolol, nebivolol, those kind of drugs. And then calcium channel blockers. So those, the non-dihydropyridine calcium channel blockers will block calcium or slow calcium movement in the heart and decrease contractility and slow down our cardiac output and lower our blood pressure. There's also drugs like alpha blockers that cause vasodilation by blocking alpha receptors. in the tunica media of blood vessels as well. But that's a good overview of blood pressure.